Hello, topic of our lecture, periodontitis in children. Today we speak about classification, about treatment of periodontitis, about clinic etiology factors. Um, Periodontitis is an inflammatory process in periodontal tissues that develops in children under the influence of trauma, and chemical agents. Of course, as a consequence of the pulpal diseases, of pulpal necrosis, pathological changes can occur in the periodicular tissues. Periodicular lesions have been classified based on different clinical and histological findings. For example, first group, it is symptomatic or acute form of apical periodontitis. The second group, it is asymptomatic or chronic disease, chronic periodontitis. And the third group, it is condensing osteitis. And the fourth group, it is different apical abscess. For example, lesion associated with the pain or swelling, it can be acute, and those with mild or no symptoms such as chronic. Classification of periodontitis. We use a classification that you can see on our picture now. It is first group acute periodontitis to form here acute cirrhosis and purulent periodontitis. The second group, it is chronic periodontitis. Three groups here: fibrous, granulating, and granulomatosis periodontitis. And the third group, it is exacerbated chronic periodontitis. Method of examination. Apical periodontitis can be symptomatic and asymptomatic, acute and chronic form. We can identify initial extension of pulpal inflammation into the periodicular regions leading of inflammation or periodontal tissues. Symptomatic acute periodontitis is characterized by moderate and to severe pain, especially on biting and on percussion. And we can doing different radiographic changes, such as widening of periodontal ligament space may not be applicable initially. Treatment in this way, it is pulpectomy and root canal treatment or extraction. Diagnostic features. First of all, it is pain. An accurate history may be obtained of the type of pain, including its duration, frequency, location, and spread, as well as aggravated and relieving factors. So, a positive history of tooth age suggests definite the pulp pathology. However, it is difficult to correlate the type of a pain with the degree of pathosis. Sensitivity of thermal stimuli, it can be indicated the vital pulp. Momentary pain may be due to exposure of dentin from leaking, restoration, or an open lesion, and the pathosis is confined of the coronal part of pulp. And persistent It is probing and translumination. Percussion. It is persistent pain, indicates widespread inflammation of the pulp extending throughout the radicular inflammation. Sorry, the radicular inflammation. Temperature test or cold test. We can use dichlorofluoromethane and carbon dioxide, or the simple method with pieces of ice or ethyl chloride. Here you can see different temperatures. And temperature test head with warm water. Electrodontodiagnosis. So pain on percussion indicates that supporting periodontal fibers are inflamed. Depression of the tooth results in pain, and the tooth may be slightly elevated from the socket and in premature occlusion. So swelling. It may be present intraorally or extraorally. Intraoral swelling. It is usually apparent of the buccal aspect of the alveolus. There is less bone or the buccal aspect than of the lingual or palatal side. So through which the inflammatory products from the periapical or interradicular tissues penetrate and taking the path of the least resistant. X-ray. So the tissues adjacent to the fistula is inflamed. So once the fistula is formed, lesion is seldom acute and becomes a chronic lesion. Extraoral swelling. It is due to the spread to exudate into various spaces along the facial planes. So in the mandibular arch, submandibular region is commonly involved, and in the maxillary margin arch, the swelling may extend up to the infraorbital margin, may involve the upper eyelid, or may be so severe as to close the child's eye. Here you can see a pathological process and resorption of one of the roots. Look here, please. Growth area. It is growth area. Look, please. It is compact granula of tooth and a resorption of one of the roots. Acute periodontitis of temporary teeth, so complaints patient have constant itching pain, and patient feel that the tooth may be grown up, and inability to chew. objectively intact tools. So when we have, for example, traumatic factors of periodontitis, in this case, tooth will be intact. Careless tooth or with signs of previous treatment. Vertical and horizontal percussion can be positive. Tooth mobility or varying degrees, and the mucous membrane of the gums near the causative tooth is hyperemic, swollen, and painful on palpation. Uh, Differential diagnosis. Tooth can have different discoloration. A tooth that is non-vital tend to have a darker color than intact tooth. Tooth with internal resorption at the pulp chamber tend to appear pink. Hence the name, it is pink tooth. Mobility associated with a deciduous tooth and may be physiological or may be due to any persistent and pathology. Radiographic evaluation of the root of deciduous tooth, the position of the developing tooth and amount of root completion of permanent tooth with determine the cause. Pathological mobility is associated with pathologic tooth resorption or bone resorption. Vitality tests, pulp vitality tests, either thermal or electrical test, are of little value in primary teeth. While they may sometimes give an indication of pulp vitality, their response does not identify the degree of pathology present. More importantly, a normal healthy primary teeth may not respond to vitality test. So the real value of a vitality test, either thermal or electrical, is in the permanent teeth, where comparison can be made with normal entimeres. The obvious example involves traumatized incisors, where serial testing may reveal the progress of the health of the pulp. Recording the blood flow in the pulp is an accurate indicator with regards to its status. Radiographs. They provide information regarding the dental development, pathological entity, position of the permanent tooth bud, and etc. So one factor that must be remembered is that the lesion must be of sufficient to appear radiographically and must involve the cortical bone. It is initial stage may be annotated. Pathological entities that can be commonly observed are pulp calcification, internal resorption, external resorption, or bone resorption, all of which may alter the treatment plan. Internal resorption is associated with spontaneous pain at night, and both the coronal and radicular part is inflamed. This contraindicates single-visit pulpotomy, and if the resorption is via extraction, may be the only choice. Bone resorption is associated with a non-vital pulp and may range from mild to severe bone loss depending on the presence of the persistent irritation. Pulp calcification represents the pulp response to a long-standing lesion and is associated with pulpal degeneration. And this counter-education single visit pulpotomy. So. We know different type of pulpotomy of pulp therapy. Sorry. Deciduous teeth. We have four methods: indirect pulp capping, direct pulp capping, pulpotomy, and pulpectomy. Young permanent teeth, here we know indirect pulp capping, pulpotomy or epixagenesis, and epixification. Pulpectomy and epixification are non-vital therapies. Remaining are vital therapies. And differential diagnosis. Chronic periodontitis is the acute stage, acute periodontitis, and acute odontogenic osteomyelitis. So, chronic periodontitis develops as primary chronic, asymptomatic, develop with a closed tooth cavity and with a shallow carious cavity. The granulation form of chronic periodontitis predominates, and pathological resorption of the root of temporary teeth is often observed. And granulating form of periodontitis is accompanied by the formation of fistulas of the gum. Granulation periodontitis. This form, when you're doing X-ray, you can see near the roots of the temporary tooth spread of the follicle of the corresponding permanent teeth and disrupt its development. Maybe accompanied by chronic lymphadenitis and sometimes chronic periosteal reaction. Maybe accompanied by chronic forms of pulpitis, granulation tissues going beyond the periodontal gap and can cause a perforation of the bottom of the tooth cavity or root wall. Chronic granulation periodontitis, it is fistula. Look on the first picture and the second picture. So you can take one very thin good aperture and do an X-ray, and you can see on X-ray the pain tooth. Chronic granulation periodontitis. Look, please. Chronic granulating periodontitis complaints more often this form is asymptomatic. But you can see tooth discoloration, fistula on the gums, and bad breath. Objectively, tooths have some discoloration, carious or sealed, percussion is painless, sounding of the cavity and the mouth of root canals is painless. Then positive symptom of vasoparesis according by Lukomsky, congestive gingival hyperemia, and possible fistula with purulent discharge or granulation. Differential diagnosis, it is chronic fibrotic periodontitis, granulomatous, odontogenic osteomyelitis, and gangrenous pulpitis. Differential diagnosis of chronic periodontitis. Treatment of periodontitis of temporary teeth. Methods of treatment can be conservative or surgical. Very necessarily, it is to decide what type of treatment you can use and stage of development of root of the temporary tooth, process flow and site of this process, so the prevalence to the process in bone tissue and its relationship with the rudiment of the permanent tooth with the follicular, and thematic and mental stage of the child. Counter-education to conservative methods of treatment. You should know that tooth is a source of septic stage, chronic infection, and intoxication of the body. And a child with a burdened pathology. Pathological resorption above 1 and 3 of the root length, and destruction of the compact plate that surrounds the follicle of a permanent tooth. That then you after you doing X-ray. Significant destruction of the crowns of temporary teeth if before the physiological shift less than 1 and 5 years, sometimes 2 years. If you know that after 2 years will be a new tooth, so we don't use conservative method of treatment. Perforated teeth, single or multiply, and teeth 3 degrees of mobility. If a temporary tooth interferes with the eruption of the permanent tooth. And when we need such a way of treatment, presence of orthodontic indications. And principles of the treatment. I should tell you about indirect pulp capping. But it is this method you can use in deciduous teeth and in permanent teeth. Indirect pulp capping is defined as a procedure in which a material is placed over the thin partition of in which a material is placed over the thin remain caries dentin. So this technique shows some success in teeth with the absence or symptomatology and with a radiographic evidence of pathosis. Indication of this method, it is deep caries in which the pulpal inflammation has been judged to be minimal, and complete removal of caries would probably cause pulpal explosion. Now we should know about impact of the macrochannel system, microchannel system, and influence of the system of periapical tissues. So periodontitis you can treat in 1 visit, 2 visits, or 3 visits. Influence on the microchannel system is electronic microscopy pictures. Aseptic rules. So it is clean K file, and it is your work instruments. On one part you can work with clean instruments, and the other part for that material that you can use that you are using in the root canals. Treatment of acute periodontitis. The pulpectomy definition. We should removal of the entire pulp and subsequent filling of the canals of the primary teeth with a suitable resorbable material. Indication of this method: the first, it is primary teeth with pulp inflammation extending beyond their coronal pulp. The second, root and alveolar bone with minimum pathologic resorption. Then primary teeth with necrotic pulp and or different periapical abscess. And the fourth, it is path at the clinical pulp exposure site. Contraindication of this method: it is grossly destroyed tooth that is non-restorable clinically. Second, periodicular involvement extending to the permanent tooth, but where the risk of damage to the permanent tooth is high. The third, this root resorption, internal or external resorption. Then extensive mobility and gross bone loss at the apex or at the furcation. You should know different types of this method of pulpectomy. Pulpectomy can be of two types: single visit or multi-visit pulpectomy, depending on the number of appointments required. A single visit pulpectomy is generally carried out as extension of pulpotomy procedure, probably as an on-the-spot decision when hemorrhage from the amputated radicular pulp stumps appear dark red, normally hairless, bleeding is bright red in color, and is uncontrollable, which indicated of the inflamed tissues. Other indication of single visit pulpectomy is tooth with a history of spontaneous pain without pulp necrosis, abscess, or a fistula. A procedure of single visit, it is done under local anesthesia and rubber dam isolation. Second, it is you should remove all carious tissues. Then entire root of the pulp, and you can use burrs, different types. Then the coronal pulp is removed with a round burrs or spoon excavator. Pulp chamber is washed thoroughly and remove all debris that you can see in the cavity. Canals are enlarged with the aim of removing all the infected dentin and providing space for adequate obturation. Headstrong files are recommended since they remove hard tissue only, or withdrawal with prevent pushing infected materials through the episodes. Disadvantages of headstrong file is that it is weak, chances of breakage is high. So K-flex file strong and hands and more resistant to fracture. Filling is done alone with the use of lubricants. So 5% sodium hypochlorite, hydrogen peroxide, saline, etc. And you can use their irrigation, or you can use different two types of acid. It is citric acid, 40%, or you can use ethylenediamine tetraphosphoric acid percent in this acid from 15 to 17%. So you can use sodium hypochlorite from 1% to 5.25% for organic tissues, and acid you can use for non-organic tissues. Then the canals should be instrumented to the resistance point that usually corresponds to 2-3 millimeters from the radiographic apex. Each canal can be enlarged 3-4 instrument size greater than the first file. If you start work in the tooth, for example, 10 file, then you should take 4 sizes, 3-4 sizes, 4 sizes instruments greater. So if you take 10, you should finish your instrumental work on 25-30. Understand? Then radiograph with the endodontic instrument need not be taken for working lens determination. Then canals are irrigated with saline and dried. Paper points are used for drying their canal walls. Canals are then obturated with suitable resorbable filling material. Zinc oxide F-genol mix is placed over the obturation material, and a tooth is sealed with amalgam restoration and finally restored with stainless steel crown restoration. Or you can do in restoration with composite. Or if you have previous very caries destroyed tooth, so the next treatment will be orthopedic treatment with using crowns restoration. So treatment: X-ray diagnosis, preparation, opening the tooth cavity, taking into account of the topography, decay removal, instrumental and drug treatment, irrigation of the root canals. The stage of the formed roots: open the apical opening, assign oral bath with 0.5-1% sodium bicarbonate solution, not solid food. Close the tooth with food, frequent fluid intake. Second visit you can do for the next day. Under antiseptic treatment, carry out and audit of the root canals, control special paper with antiseptics, with in this case iodinol, does not change color if you use these antiseptics. And an antiseptic spot is left over the mouth of the canal, and the tooth is closed with an artrite dressing. The third visit in 2-3 days. Hermetic dressing must be maintained, so hermetic restoration. Remove the tight restoration to carry out instrumental and medical treatment of root canals, canal filling, perform X-ray diagnostic, and put a permanent seal. Um, Multi-visit pulpectomy used for non-vital primary teeth with or without associated abscess. Clinical techniques is similar to single-visit pulpectomy, but the procedures are not done on the first visit. On the first visit, pulp is extirpated, canals are irrigated, dried, and the tooth is temporarily restored. On the second visit, the canals are enlarged, and if all the symptoms have subsided, the tooth is obturated and permanently restored. Obturation is postponed until the symptoms regress. So between appointment and antibacterial drug is sealed in the pulp chamber. If pus is present, the canal can be left open to drain for 24 hours. And systemic antibiotics are advised in cellulitis is present. The number of appointment, timing, and extent of instrumental thus will be determined by the signs and symptoms at each visit. So the first visit, the simple X-ray diagnosis, preparation, opening the tooth cavity, creation of the antiseptics depot, and layer by layer removal of decay, as well as infected predentin and from the walls of the root canals. This is very necessary because in permanent teeth in root canals we have very big amount of infected dentin. Antiseptic root canal treatment: introduce antiseptic turons or points into the root canals and apply a hermetic fill. Second visit, remove temporary restoration, drug and mechanical, so irrigation and mechanical treatment of root canals, root canal fillings, X-ray control, and permanent filling. Treatment of toxic periodontitis: first visit, this X-ray, preparation, opening of the tooth cavity, remove pulp from the root canals, use an antidote. Please look and pay attention with arsenic periodontitis, 5% solution of onitiol, 5% solution of iodine, and a 1% solution of iodinol. In case of phenol damage, castor oil or 10% anesthetizing emulsion in castor oil. And close with restoration. Second visit, remove your previous restoration, antiseptic and mechanical treatment of root canal filling, X-ray control, and permanent filling. Root canal treatment products. Filling or obturation of deciduous root canals. Ideal requirements of material used. First of all, they must be resorbable, should not interfere with eruption of permanent tooth, should be bactericidal, must be radiopaque, and must be a non-irritant for periapical tissues. Chlorine-containing preparation, 2% chloramine solution, 2% solution of sodium hypochlorite. Look, please, you can use from 0.5% to 5.25%. If you know that you work with vital pulp and you should take out all debris, all necrosis pulp, you should take hypochlorite. But if you know that, for example, it is first molar, child has, for example, 7 years old, and you know that in this molar you patient have a growth area, and root canal will be very wide. Please, in this way, don't take hypochlorite, because you can take because you can irrigate, you can do in your irrigation out the growth area, and finally patient will be have necrosis of bone of growth area. It is very bad prognosis. Then if you work with such cases, you can use chlorhexidine, for example. Then a solution of 3% sodium hypochlorite, so per can solution, histolith, and chloreucalyptus. Antiseptics of the nitrofuran series, it is 0.5% solution of furacilin, and 0.1, 0.15 solution of furazolidone and furagine, 0.5, 1% solution of dioxidine. Guys, if you work in your test box, then you should learn these antiseptics. They can be in your test tasks. But for your clinical and practice work, please remember about sodium hypochlorite, different percent, about acid, citric and ethylenediamine tetraphosphoric acid, and percent of these solutions. Okay. Then antibacterial drugs. These names we use here in Ukraine. In your countries, maybe you have other drugs, but different containing drugs in these names are similar. So novoimanin, polymyxin M, nitroxaline, metronidazole, and gramicidine. Then different materials used. Yes, zinc oxide FGenol is used without a catalyst. Lack of catalyst is used to allow adequate working time. Iodoform paste is also being used. It consists of zinc oxide and iodoform mixed into a paste. Its advantages over zinc oxide eugenol are potent bactericidal, non-irritant, radiopaque, chemically active until entirely resorbed, good healing properties, and rate of resorption is faster. In your picture you can see um, obturation materials based on zinc oxide eugenol, zinc oxide plus eugenol, and or Grossman paste or carrier sun type of material. Of course, be attention, because as I remember, this question will be in tests. Iodoform pastes, including resorcinol formalin, liquid without catalyst, with the addition of iodoform, KRE paste, and Tempoproof, different companies, Switzerland and Septidont. 5% iodine paste, Timoform, iodine, Vladimiva, for example. 5% iodoform, thymol paste, and based on calcium hydroxide, iodoform mixture, calcite, calcimol, ultracal, calcipast, for example, different names. Iodoform paste is commercially available as KRE, and contains iodoform, camphor, parachlorophenol, and menthol. Iodoform paste is combination with an zinc oxide is available as a Meister's paste, which is an addition to the above mentioned consistence, also with thymol and lanolin. You should know such materials as Vitepex and Mitepex. These iodoform containing products resorb in advantages pushed beyond the apex, but the rate of resorption of on the material from within the canals is faster than the rate of physiological root resorption. Another root canal fillings material, a mixture of iodoform, calcium hydroxide, and zinc oxide, is commercially available as Endoflex. In addition, it has eugenol, zinc oxide, calcium hydroxide, barium sulfate, and iodine distiller orsoxazole, with a liquid consisting of eugenol and paramonochlorophenol. It is reported to resorb when extort beyond the apex, but resist resorption intraradicularly. Eugenol, one of its constituents, is known to use periapical irritation. Method of obturation. Criteria for the effectiveness of treatment of periodontitis: lack of clinical manifestation, lack of percussion, palpation of the transitional fold is painless, and the fistula can be closed on from 3 to 5 days to 10 days. No exacerbation, reduction of the source of discharge, and after 6 months, based on X-ray. The final resort you can do in dental examination during 4 years. You should do it. 4 years it is for adults. Okay. For children, after 6 months, you should do in control X-ray. Then So the materials, method of obturation. Root canals. The canals are dried throughoutly using paper points. Then you can take a lentula spiral and pressure storage. Then local anesthetic so anesthetic can be used and carry and deposit the material into the root canals. But for adults, you should don't take the lentula spiral spiral for root obturation, because if you doing for example it very quick, you have some problems with this instrument, and you can lose some part in the root canal. The material is mixed to the required consistency, and it carried and deposits in the canal just short of the apex. Then cotton held with cotton pliers can be used as to push the material into the canal. Then pressure and pressure and doing your obturation. Then a common problem with zinc oxide eugenol as deciduous tooth obturation. Zinc oxide eugenol material is harder and resorbs slowly compared to the root. And as resorption, the permanent teeth may be a small part of eruption. Then problems encountered in deciduous tooth pulpectomy. So multiply ramification makes complete debridement impossible. So ribbon-shaped or hourglass shaped canals discourage gross enlargement of the canal. So in permanent teeth, the objective of mechanical preparation is to provide as even circular apical from 1 to 3 sorts. In primary teeth, attempt to prepare circular apical, and mechanically may result in lateral perforation of the canal due to its hourglass shape. Then follow up. Monthly evaluation should be done preferably for 6 months period. We know this. Then clinic and radiographic assessment should be made. The outcome of the treatment, and following pulp therapy is advisable to place stainless steel crown to prevent the fracture of the teeth. Then exogenesis or calcium hydroxide pulpotomy, cervical pulpotomy. They remove the infected coronal pulp and place calcium hydroxide over the healthy amputated radicular stumps. Then a calcific barrier should form its response, and the radicular pulp should retain its vitality, though the root closure can occur. They achieve normal growth of the root to assume its normal length and apical closure. Calcium hydroxide pulpotomy is considered as a first stage of treatment for vital carelessly or traumatically exposed permanent teeth with incompletely formed abscess. Then maybe Yeah, apexification, very necessarily um, method. So indicated in a non-vital pulp with incompletely four open apices. So when blunderbuss canal. The toxic product from the necrotic pulp cause death of the cells, and it is almost impossible to get an accurate seal of the apex during obturation of the canal with a wide open apex. So apexification is procedure where a suitable material is obturation root canal, which aids in the formation of special calcium barrier at the apical end of the root canal. So you can use calcific material that is formed may either be osteoid, cementoid, or osteodentin. Then, alternative to apexification is apical surgery procedures by root canal therapy. This is not recommended in children because, first of all, surgical techniques should be avoided. Thin apical may be apical surgery difficult, and already short root canals, so it is not a good method in children. Then material, first it is calcium hydroxide, most preferred and first reported and popularized material. Then second it is zinc oxide paste and antibiotic paste. The first it is 3 calcium phosphate, collagen calcium phosphate gel, and mineral trioxide aggregate. Procedure of this method: first, the tooth is anesthetized and isolated. The second, excess opening is similar to conventional root canal treatment. Then, barbed broach is used to remove the pulp and necrotic debris. Diagnostic X-ray helps is in assessing in the root length. So walking length is approximately 2 millimeters from the apex. Headstrong file is used along with constant irrigation to cleanse the canal of the debris. Then canal is dried and filled with calcium hydroxide or any other desires material. Then changes of success are greatly improved when the canals is filled in the absence of inflammation. You should remember necessarily a moment about that you work in 2 or 3 millimeters higher from apex, and you can use different types of materials. Now is very popular MTA. It is mineral trioxide aggregates, and indication of these materials you can use it in the warm and not dried root canals. That's all. Thank you for attention. If you have some question, you can write your comments, you can write your messages in the Google Plus. Thank you. Bye and good luck.